Turkey, who will talk about the timing as well of optimal timing of surgery as well as radiosurgery. Over to you.
Thank you so much. And I would like to thank so much to Dr. Zileli for inviting me to this webinar and talk with the experienced leaders in this subject. So I will try to share my slides. Is it okay? Can you see the slides right now?
Yes, yes, we can see the slides.
Perfect. Okay, so I will talk about the optimal timing and the role of radiosurgery or stereotactic radiotherapy for craniopharyngiomas. Sorry. So, of course, gross total resection is aim in the treatment of craniopharyngioma. But the surgery today, what we do in surgery for craniopharyngioma does not look like what our ancestors did 50 years ago. So the neuroanatomy knowledge is improved, neuronavigation improved, surgical techniques improved, surgical ways improved, a lot of things are improved. So the results of gross total resection in those patients does not look like what we had many, many years ago. So to get the cure of the tumor from the tumor for the patient, of course, gross total resection is number one in these patients or in these tumors. However, if the tumor adherent to the optic nerves, chiasm, hypothalamus, other structures in the head, the results with subtotal resection about visual, hormonal, emotional features are better. And the quality of life is better with subtotal resection in those patients. So we should not be afraid of subtotal resection. The quality of life is the most important thing for us, not the MR after the surgery. So we can use radiation as an adjuvant treatment in these patients, and we can use fractionated radiotherapy with photons or protons, and we can do stereotactic radiosurgery, stereotactic radiotherapy for these tumors. For the gross total resection, from the articles, from the literature, we know that almost 20%, 25% of the gross total resection patients, tumors, may show recurrence. In most of them, the recurrence is due to the infiltration of the tumor into the neighboring neural tissue. In the surgery, you may think that I have already took everything out. And when you see the MR, everything is out. There is nothing left there. But when you check all the areas histopathologically, of course, you cannot do it, but you will see some infiltration, and these infiltration may cause recurrence of the tumor, and we already know it from the articles since many years. So this is a nice article, shows us that, of course, there are not so many patients, but it shows us that, please look at this graph here. So if a patient has subtotal resection, the progression-free survival drops down very easily, very quickly. If a patient has gross total resection, it is nicer than subtotal resection, of course. But if a patient has subtotal resection plus radiation, the progression-free survival is much more better than these other two. So radiation really gives some benefit for these patients. So how can we use radiation for these patients? We can use fractionated radiotherapy with photons. Photons here means X-ray. So in this article here from Aldave and the colleagues, they compared the gross total resection and partial resection with radiotherapy. And they found that if the patient has partial resection plus radiotherapy, their cognitive function and the quality of life is better than gross total resection. So for this group of patients in their group, they operated 43 patients. Their comment is like this. So when we operate a patient with craniopharyngioma, if we have a subtotal resection and there is some residual part there, should we irradiate them immediately or later? And this article compares both arms, and they saw that if you irradiate the residual tumor without waiting for the growth of that residual part, it's better for the patient, for the progression-free survival. So our advice is not to wait after some weeks, for example, after the surgery, irradiate the residual part. Here in this article, they looked for the series with 101 patients who had photon radiation therapy, radiotherapy. And the interesting thing is you can see here that they give 5 millimeter to 1 centimeter CTV margin. It's a huge margin. In radiosurgery, you don't do this. But in radiotherapy, they did this. So it means that, can you imagine 1 centimeter of normal hypothalamus, normal temporal lobe, etc., frontal lobe received radiation. So they found that IQ is lower in the follow-up in those patients if they are treated in younger age and if the patient has high doses to the hippocampus and the temporal lobe. And of course, IQ is very important for the quality of life of the patients. And they found that if the patient is treated for the growth hormone deficiency, they respond well to the treatment in this series. And if the patient has impaired baseline vision, also they have bad outcome. And in this article by Edmondson and his colleagues, their summary is the key points are overall survival is excellent in children with craniopharyngioma treated with radiotherapy. So they advocate using radiotherapy. Tumor, host, and radiotherapy factors impact survival and the risk of complications, of course. And the reducing target volume margins and radiation dose exposure should be a priority. You see here, reduce target volume margins. So to do radiosurgery instead of fractionated radiotherapy would be a better option for the patient who can have this treatment, I mean radiosurgery. Sorry. So for fractionated radiotherapy, we can use protons. So there are a lot of articles about proton treatment for these patients. And you see here, this is a large series with 77 patients, and they checked the results of the series, and they say that the late toxicity in these patients, you can see moya-moya syndrome in 13%, visual impairment in 40%, and endocrine deficiency requiring hormone replacement in more than 90% of the patients. So huge side effects of radiation in those patients. And this article compared photon and proton, and they checked for different issues: overall survival, progression-free survival, radiation necrosis, vasculopathy, vision, etc. Which one is better, photon or proton? And they found that there is no difference. So the photon and proton is almost same. So there are a lot of proton centers, particle therapy centers in the world, and most of them in the United States, you can see in these charts. In Turkey, we don't have any particle therapy center yet, but there are a lot of particle therapy centers in the world, and it's exploding a lot of in the latest years. But in this comment, Grossman and Kosmin said that to do proton therapy for craniopharyngioma, does it worth the expense? Because you know that proton therapy is very expensive. And their comment is saying that radiosurgery using platforms such as CyberKnife or Gamma Knife, etc., can be enough for these patients. This doesn't worth for those expense. So this is an interesting series. I want to show it to you all. And this is a small series, of course, with 13 patients. They didn't do any surgery for those patients, for those pediatric patients. They give radiation with proton. You see here the proton treatment for these patients, and they found 5 years progression-free survival, 100%, and 10 years, 75%. But I think this can be used in a very, very selected cases with craniopharyngioma. So when we come to stereotactic radiosurgery and stereotactic radiotherapy, you can find a lot of articles in the literature about this. Most of the articles are belong to Gamma Knife series. And there are, of course, some articles about CyberKnife and our Linux-based systems. But here, in this article from Japan, they also reviewed the literature, and they found that their 3, 5, and 10-year overall survival rate with Gamma Knife were 95%, 92%, and 82%. But if you check for the progression-free survival, it is 73, 62, and 46. So it means that if you wait a lot, you will see a recurrence in those tumors. And the rate of the radiation-induced complication was in this series was 6%. But when we are talking about the recurrence after radiosurgery, we should think about this. Is that recurrence from the irradiated area, or is that recurrence from the other side of the surgical bed? That's very important, because with radiosurgery, you only irradiate the residual tumor there. You don't irradiate the other areas of the surgical bed. So if you see a recurrence in the other areas of the surgical bed, it doesn't mean a recurrence of tumor after radiosurgery. This is a almost natural history of the tumor. In this article, the authors checked for the body mass index after radiotherapy and radiosurgery, and they found that radiotherapy patients become more obese because you do give more radiation to the hypothalamic structures. So those may cause obesity in these patients. So to have this kind of obesity, of course, makes the quality of life less in those patients. In this table, you will see the comparison of the two techniques. In the first part, you see here the radiotherapy, okay, external beam radiotherapy, and here radiosurgery. The success rate, the tumor control rate, almost same, not so much difference. But when you check the morbidity, the radiotherapy series have high morbidity than the radiosurgery series. So the message should be for us is, if a patient's residual tumor is a good candidate for radiosurgery, do radiosurgery. Don't do all area radiotherapy, because you can repeat radiosurgery for the tumors which are recurring in the other parts of the surgical bed. Yes, and about the doses, of course, some of the friends here are experienced with radiosurgery. We try to give around 12 to 14 gray, 15 gray for those patients, and we try to keep more than 12 gray. Of course, if the tumor is very close to optic nerve or chiasm, etc., sometimes we keep the doses less than 12, but every time we try to give more than 12 gray for these patients. So about the complication, of course, same thing. The marginal dose, maximum dose are important. Of course, if you give very high, for example, 17 gray, 18 gray to a craniopharyngioma, you may see a lot of complication related to this, related to that high radiation. So in this article by Losa and colleagues, they compared one session gamma knife radiosurgery with 3 sessions of gamma knife radiosurgery. You can see here that the 3-session, multi-session gamma knife radiosurgery patients, they have larger tumors than the single fraction, single session gamma knife radiosurgery. But they didn't find any difference in the results about the success, I mean the tumoral growth control rate, about the complication, and they say that they commented you can use both of them, but in our experience, if the tumor is not very close to optic nerve or chiasm, we try to do it with single fraction, but if the tumor is very close to optic apparatus, we do use multi-session treatment. And as I said, that there are some series in this about cyber knife treatment, and the results are almost same with the gamma knife series. So with cyber knife also you can use radiosurgery for these residual or sometimes recurrent tumors. And in this article they search for the SRS and the fractionated stereotactic radiotherapy, and they didn't use huge amount of margin for the CTV. They only use maximum 1 millimeter of CTV. So there is no difference between SRS and fractional radiotherapy in this small series. We also published our results with hypofractionated gamma knife radiosurgery for residual or recurrent craniopharyngiomas. There were 24 patients, and our 2-year progression-free survival rate is 81%, and 4-year it is 61%. When you check the literature, you will see the results about same. So you can use, but of course you may should, and also the patient should know that we can see the recurrence after the treatment. But where is the recurrence? That's the important thing. I will show you some examples from our patients. This is a 43-year-old male. He had 1 transfemoral surgery, and there is a residual tumor there, 1.5 cubic centimeters, and we gave 15 gray to this tumor because it's very far away from the optic nerve. It is for us, for radiosurgery, it is far away from the optic nerve. So the 30-month follow-up MR image shows complete resolution of the tumor. And in this patient with 32-year-old female patient who had 2 craniotomies for the craniopharyngioma, and she has no vision on the right side. And we gave 10 gray to the tumor to keep the chiasm and the left optic nerve healthy, because it's very important in this patient. And she responded well to this treatment. And you see here the result of 25 months follow-up MR image. Another patient with a large craniopharyngioma, you see she's a 25-year-old female with vision decrease. And because of this tumor is very close to optic nerve, chiasm, etc., we decided to give the treatment in 5 fractions, 5 consecutive days. And this is the image from the treatment day, and this is the image from the 1-year follow-up. So, and we didn't get any visual problem in this patient. And in this patient, it is also another cystic craniopharyngioma. This adult patient had craniotomy for this tumor, and there is a residual, and then growth, demonstrated the growth of the cyst here. And also he had 5 fractions of treatment with gamma knife radiosurgery. And you see here the volume of the cyst goes down in the 15 month. So in our experience, and in also the experience of the many centers, we can say that if we see a recurrence after radiosurgery, in almost all of the time, the recurrence is cystic, not the solid part of the tumor, the cystic part. So like in this patient, you see a cystic recurrence on the left side of the supracellular area. Of course, you have to decide about to do a second radiosurgery or to do a fractionated radiotherapy or to do a surgery or implant Ommaya reservoir. It depends on the patient's MR image. And this article, a review article, shows that you can deal with craniopharyngioma, but in every arm, you may need a radiation. So in every arm, you may need a radiation. So we have to use the proper one and with the experienced hands, of course. And this is an overall summary of the this presentation you see here. Please look at that. You do see a lot of lines here in this graphic, and subtotal resection plus radiotherapy gives more cumulative survival rate when you compare with the other ones. So for the conclusion, I would say that, of course, our aim is to gross total resection. There's no question about it. But we shouldn't push for gross total resection. Subtotal resection is also acceptable. And with subtotal resection, radiation treatment should be done after surgery in a few weeks. Don't wait for many months or years. Single session for small tumors we do use. If the tumor is larger and if the tumor is closer to optic nerve, chiasm, etc., we use hypofractionated treatment. But if a patient has a large tumor, and if I cannot see properly the optic nerve or the chiasm in the MR image, then we advise to have fractionated radiotherapy, because I don't see where the optic nerve is. I cannot keep it healthy. So we use fractionated radiotherapy for them. And in a very small group of selected patients, you can use radiation treatment as a primary treatment. Thank you so much. So I stopped my sharing.
Please, Regunath, do you want to ask to Professor Selçuk if there are some questions from the audience? Regunath?
Sabino, can I have a comment?
Sure, Professor.
Thank you, Professor Selçuk, for your talk, and you've mentioned a lot of important points to follow, and in terms of how to plan the treatment and so forth, and especially the low dose and the attention to the optic nerve and all the different aspects of it. However, I would stress, hopefully, in the future, that if you notice, the literature is full of publications on radiotherapy, and there is very few for surgery. And unfortunately, this is because of the wrong approach that has been done historically. We should have much less people who need radiation therapy, but we have more people who end up. And in some of the pictures he showed, there's a massive amount of tumor left, and a residual should not be as big as what we've seen. And that has to be corrected in the future. A residual is like the pictures I've shown, where there is a small piece attached to the brainstem and the perforators. And in that case, we will follow it very closely. And he's right, there is more cystic components that are seen, but it doesn't mean only the cyst grow. It means the solid part grown, and then the cystic part showed up. And when you have a cystic part, you're really radiating a larger area of the tumor, and it should not be the case. You should always aspire to the smallest piece ever in this case. So I hope the future will be a different approach. And I myself think that I myself do radiosurgery, but I rarely use it. I have used it in a couple of patients, 3 patients so far. And that's how it should be. I think in the future, the neurosurgeon who's very capable of treating a craniopharyngioma should be the one who will plan the radiosurgical treatment, because they know how far they can do and how far they can go. And I think this is the best for the patient. This is not about, what's best for me or for the other surgeon or other doctor and so forth. Again, like I showed that picture of the train has moved, I can tell you the train has moved. The future is going to be different because we have different approaches now. We are capable of doing more for these cases. And, Dr. Selçuk showed in his conclusion, the first sentence was, don't push for gross total resection. I agree with him, don't push, but be prepared for gross total resection. And it has to be drilled in everybody's mind that hypothalamic injury and dysfunction and morbidity are caused by the ill-prepared surgeon. And I'll invite anybody to come to Little Rock. You have been here, Sabino, you've seen what we do to our patients.
Sure.
If you know what you're doing, you know the anatomy. But the problem is too many ill-prepared surgeons have jumped into doing craniopharyngiomas and ended up with catastrophes. And this is not, should be the accepted routine. We have to change it. And trust me, if any one of those of us listening, you have a loved one or yourself, that you have a problem like craniopharyngioma, and it can be resected with a great margin of safety and cured, that's the way to go.
Thank you, Professor. Thank you for this comment. And if there are no further questions from the audience.
Dr. Selçuk, maybe I'll just add something. So it's a nice flip side of things, evidence that you've shared with us. I would just like to pose one question to you. When do you think, from a radiosurgeon's perspective, when would you advocate or push, or say not push, advocate for gross total resection in a craniopharyngioma? We've seen spectrum of cases, but in your opinion, when do you go for gross total?
Craniopharyngiomas are not very frequent tumors. We do see 1 in 1 million. For example, in Turkey, 85 million inhabitants, only 80-something craniopharyngiomas in Turkey every year. So all the neurosurgeons shouldn't need to operate craniopharyngioma. So the experience is very important. Experience is important with surgery, and also experience is very important with radiosurgery also. So if you get an education with an experienced surgeon, who performs craniopharyngioma surgery a lot, then you can understand when to push for gross total resection, when to try to get gross total resection, when not to have. You may discriminate between only the adherence of the tumor to the optic nerve or the infiltration of the optic nerve. So I would recommend to the young colleagues, as Dr. Ali said, that they should need some good experience from the good education from the experienced surgeons all over the world.
Understood. So thank you for that perspective. So it's nice to hear both sides of the coin. Now I think we are inspired by both your talks. Our last speaker